All right. Welcome to week 3, everybody. Thank you all for coming. Just pull up my stuff here. Okay.
You get your hair cut?
I did.
Wow. Looks great.
Thank you. Thank you very much. Yeah, I thought time for a change is what I was thinking. So, yeah, this is the shortest I've ever had it in my entire life. It's
Wow.
very different, very different. My daughter actually got her hair cut real short as well. So we look even more like twins.
Wow.
Okay, so we're all about labor today. All right, so I've got a couple case studies I got planned for us to go through. I'm going to do some overviews on a couple of the topics that I just want to draw your attention to. Make sure that you check out the lecture recordings that I have posted on Module 3. I've also posted some additional handouts under Module 3 that hopefully will help you with labor. And let's get going. All right. So the labor process. Let's talk about the 5 P's. The powers, which are the contractions, and the mom's pushing efforts. That is considered the powers when we talk about powers. Passenger, that is the fetus and the placenta. They are both considered passengers because they are both delivered during the labor process. Passageway, which is the mom's pelvis. And then the passageway passenger relationship. So now we're talking about when the baby's presenting part engages into that maternal pelvis and where the baby is stationed, right? What is the station of the baby? And then the last one is the psychological influences. Now this is where we're talking about mom's previous pain experiences that she may have had in the past. Remember, labor, it's very painful. There's lots of pain involved in labor with the contractions, okay? The cramping of that uterus to push the baby down to be able to get out through the birth canal. So it's very painful. So we think about psychological influences as if she's had previous bad experiences with pain, she may have a lot of anxiety having to go through that labor process. Think about a new mom, right? She's never had a baby before. It could be very terrifying for her to be going through that labor process the first time. So those psychological influences can have an impact on the entire process. Okay, we want that process to be as positive as possible. I mean, the pain is going to happen no matter what we do. Even if we give her medications, she's still going to be having some pain with this process. That's unavoidable. So we want to make sure that we're trying to make it as positive a process as possible. So make sure that you review those 5 P's. That's going to be pretty important information. Did you have any questions real quick before we move on to the next part of what I want to talk about? I want to have as much time as we need for our case studies today because I think they're going to be very helpful for you guys. But any questions before I move on the 5 P's? Does that make sense? Pretty straightforward? Okay. All right. I'm trying to keep my eye on the chat. I seem to lose track of that as we go along. So labor is divided in 2 stages. So we're going to talk about the first, the second, and the third. And we'll just very briefly touch on the 4th. We're going to cover the 4th stage more next week when we talk about postpartum. But the first stage is considered the dilation stage. This is where the cervix is dilating and what we call effacing. So what do we mean when we say effacing? Does anybody know what that means?
The thinning of the cervix.
Yes, excellent. Thank you very much. Yes, the thinning of that cervix. So we need the cervix to dilate and we need it to thin. So the first stage is divided up into 3 phases, okay? The latent phase, which there's not a lot of contraction happening. The contractions are not real intense. They may be up to 10 minutes apart, so they're not real close together. And we anticipate that that cervix is going to dilate anywhere from 0 to 3 centimeters. So the first 3 centimeters of dilation is considered the latent phase. Now, this can take a lot of time, especially if they are a first pregnancy. The first pregnancy, the labor process usually takes the longest, okay? Once we've passed that stage or phase, then we're getting into the active. And active meaning now the contractions are coming closer. They're lasting a little bit longer. They could last up to 60 seconds, which when you're having pain, that can be a long time. They're also going to be more intense, okay? And obviously, when we're having them closer together, they're stronger, they're lasting longer, they're more intense. We're going to be having more dilation. So this is anywhere between 4 centimeters and 7. Now, if you look at my picture there, you can kind of get a visual. So we're starting with number 4, and we end up at number 7 during the active phase. Okay? When we get to the transition phase of that first stage, that's a lot of times where mom is pretty exhausted. A lot of times you might hear her make comments like, I can't do this anymore. When is this going to be done? How much longer? I'm so exhausted. I can't handle this anymore. This is a lot of time where she just wants everything to be done and the baby to be here. Because now she has spent several hours going through these contractions, and it's a very laborious process. That's why we call it labor, because it's very intense. Okay, the body is going through a laborious process in order for this baby to be born. So during transition, the contractions are very close together. They might be a minute or 2 apart, and that's it. They are lasting much longer, could last up to 90 seconds. Think about, for those of you that have never had babies before, you have no idea what the contractions feel like. Think about a Charlie horse. That's the best analogy I can give you. A Charlie horse that lasts 90 seconds. Now, you've all had Charlie horses in the past in your calves, and you know how painful those are. Those wake me up from a dead sleep, and I jump out of bed sometimes. So that's how intense these contractions are once we get into transition. Very, very, very intense. So now we're going from 8 centimeters to completely dilated, which is 10. Complete dilation is 10 centimeters. Okay, effacement, on the other hand, that is in percentages, because we're talking about the thinning of the cervix, right? So if we have complete dilation at 10 centimeters, complete effacement is 100%. Okay, so now we're ready to push. We're completely dilated, we're completely effaced, we're ready to push. That is what the second stage is. The second stage is the pushing stage. This is where we are doing a lot of work to get baby out. So starting at the full dilation of the cervix until the birth of the fetus, that is the second stage where we are pushing. Does that make sense for everybody? Yes? Okay. Now, once we're doing the pushing and the baby is born, now we're into the third stage. The third stage focuses a lot on the newborn, right? Because now we have the baby. The baby's here. So we have to make sure baby is stable, okay? We have to make sure that baby is doing well. Plus, we have to deliver that placenta, because the placenta is delivered, right? There's more contractions that are needed. Mom has to actually push that placenta out. It's not like baby comes out and mom's completely done. She's not done yet. She still has to deliver that placenta. And we are also monitoring mom, okay? So there's a lot of things happening during that third stage. We have to make sure mom and baby are stable. We want to put that baby skin to skin so they get that first initial skin to skin contact. We want to try and get that first breastfeeding done if we possibly can during that third stage, during that first hour after delivery. We have to make sure everybody's stable. We got to make sure that that placenta is delivered. So there's a lot of work that's done. Plus there's a lot of monitoring that's done. The fourth stage, that's generally that first couple of hours after delivery. right? Where the bonding process is starting, the family is getting together, mom and significant other or dad are seeing that baby for the first time. We're doing that first breastfeeding, right? We apply the bands to make sure that we're initiating that infant safety. So we're putting the bands on the baby, putting the bands on mom, putting the bands on the third person, making sure that everybody's ID'd appropriately. We give the baby their meds, right? The eyes and thighs, erythromycin to the eyes, vitamin K to the thigh. So we're doing all of those types of things during that fourth stage. And like I said when we started, I'm going to talk more about that next week when we talk about postpartum. I don't want to spend too much time on that this week because today we're talking about labor. And I want the focus to just be on labor. Okay? All right. Any questions over any of that I just covered? Does that make sense for everybody? It's going to be real important that you guys have a clear understanding of this. Okay. All right. I'm moving on then. All right. So we talked last week a little bit about fetal monitoring. So this is obviously going to be extremely important during that labor process. So intrapartal assessment of the fetus during the labor process is going to be very, very important to the outcome. So intrapartal, that means you're actually during labor. Antepartum means before labor. Intrapartum means during the labor process, actually during labor. Postpartum is after labor. Okay, does that make sense for everybody when I explain it like that? Antepartum is before labor, intrapartum during labor, postpartum after labor. Okay, so we have to monitor that baby. So there's a couple of different ways that we do this. We do the external fetal monitoring, right? We put the monitor on mom, and that is monitoring the uterus. So we're looking at those contractions. We want to see how strong they are, how adequate they are. It's also looking at baby's heart rate. Okay, so those are the couple of ways that we monitor baby. We are monitoring mom's uterus, making sure that the contractions are good and strong and everything looks good there, but we are also monitoring baby's heart rate. Another way that we do it is by the positioning of baby. Where is baby? What's the positioning? Well, that's very, very important because if baby is not in the appropriate position, then delivery is going to be complicated. Okay, it may not even be able to happen in the vaginal sense if baby's not positioned appropriately. Okay, so we do vaginal exams. We also do the Leopold's maneuvers. All right, so tell me what the Leopold's maneuvers are. Does anybody know what those are? Alina says pressing on mom. Okay, that's the start. Anybody can help her out? A little bit more specific about?
Feeling on the abdomen for the baby's position.
Yes, so we're using our hands, right? It's a tactile procedure. And we are taught when we work in labor, the nurse is taught how to do that. And the reason why we're taught is because that's part of our monitoring. So we want to know where baby's at. We want to know what position baby is in. It's very, very important to a successful outcome. All right. And then, of course, like I said, we're going to be monitoring the baby's heart rate with the Doppler and the total dynamometer. There's two different parts to that monitor, as you can see in the picture. And like I said, the Doppler is monitoring the baby's heart rate, and the TOCO is monitoring the uterus. Now, of course, with mom's positioning, when she moves around, that might get shuffled around a little bit, and so you're going to have to come in and make adjustments to that, right? Because she's not going to be laying on her back. We don't want her laying on her back. Why don't we want mom laying supine? There's a reason why we don't want her supine.
The weight of the uterus presses on the one nerve through the spinal cord.
The vena cava. It's going to apply pressure to the mom's vena cava. Yep. And that causes mom's heart rate and her blood pressure to drop. That causes a problem for mom. Okay. So supine hypotension. We don't want that. So even if she's like, with this picture here, it looks like she's laying on her back, but she's really not. They have a little bit of a wedge. You can't see it, but they would have a little bit of a wedge or a rolled up blanket or something under that hip to get her off of her back. We don't want her to be completely on her back. We have to have something underneath her to get her off of the back completely. Ideally, what position do we want mom to be laying in? Left lateral. Thank you, Jen. Yes, left lateral. Why do we want left lateral?
More oxygen to the baby.
There you go. Oxygen to the baby. Excellent. Good, good, good. Okay, I think you guys are ready for this case study. Let's move on. All right, so you have a 42-year-old pregnant client. She is 42 weeks gestation, and she is in the second stage of labor. Baseline fetal heart rate is 120 beats per minute. So while you're assisting her through the contraction, you observe a late deceleration to the monitor. The baby's heart rate drops to 80. So tell me, causes of this type of deceleration. What causes it? Think back to your readings.
Isn't it
What
lack of
causes it?
oxygen during the contraction?
The lack of oxygen contributes to the decel, yes, but what causes a late decel specifically?
The umbilical cord is possibly being pressed on.
No. Anybody help her out? We're going to talk more about the decels. This is a good trial. Good try. Good try, but not exactly. It's not the cord. I think somebody said it. Jen says decreased blood flow to the placenta. It has to do with the placenta. Yes, it does.
Attachment?
It could be detachment.
Starting, yeah.
I mean, yeah, it could be. It could be. Think about what is mom's gestation. Focus on that. What it is, could there be a potential problem with that?
She's past, like, isn't the max like 41 weeks?
Yes, so she's post-dates, right? Size of baby? Not necessarily, Jen. Not necessarily. It's not necessarily that the baby's too big. It's more to the time. Think about the placenta. The placenta is the baby's lifeline, right? So the placenta has X amount of weeks where we anticipate that it is fully functional. Okay, but now we've gone past that, haven't we? So now we have to be concerned that the placenta is not functioning optimally any longer. So that is what contributes to those late decels. With this particular case, this is what we're talking about. Mom is post-dates. So now, if we were the nurse taking care of this patient, which you are, for this case study, you're the nurse taking care of her, you need to start thinking that there's a problem with the placenta because mom is post-date. So that's got to be the forefront of your mind, is that now we may be having a placenta problem. And the stronger the contractions of the uterus, the more that problem is going to be shown, because every time the uterus is compressed, there is that potential that baby is going to be hypoxic, right? It's going to kind of cut off a little bit of that oxygen supply because of that squeezing, the squeezing of the uterus. And once we get into that second stage, remember we said second stage is the pushing stage. So now, you know, everything has come to a head and we're ready for baby to be delivered. Does that make sense for everybody?
Yep.
Yes? Okay, you guys did great. I'm loving this. You guys are doing good. Wonderful, wonderful, wonderful. Everything's coming to a head. Yes, Echo. Yes. Oh, yeah, I made a little play on words there. You're right. So what is our responsibility? You're the nurse. What do you got to do? You're having a late decel. Not good. So what do you have to do?
Reposition her.
Okay. How are we repositioning her?
Left side lateral.
Yep. What else do we have to do? I saw somebody flip it up there. You want to just say what you just put up there? I can't remember if it was Chelsea or.
Apply O2
Yes. And how are we applying that and how much?
via face mask.
Okay. How much?
That I don't know.
That's okay. Anybody want to help her out? She's doing great. We're doing the face mask, but we have to know how much. 10 liters, Tima. Thank you. Thank you. Yes, 10 liters. Now that some of you are going to freak out when you see that because you've been taught up until now you have to be very judicious with oxygen and we have to be careful how much we give. But the caveat to this practice setting, we're in labor, right? The oxygen is for who?
Baby.
Baby, yes. So that's why we give so much, because we're not oxygenating mom. We're oxygenating baby. Okay, because baby's having a decel. That means baby is hypoxic. So we're oxygenating baby. So when you guys are looking at these questions and you're seeing these choices, think about it. What is our responsibility? Why are we doing what we're doing? If baby's having a decel, then that means baby's hypoxic, right? There's something cutting off baby's oxygen supply, and the heart rate drops in response to that. So we need to get that baby oxygenated. The longer the baby goes without oxygen, the worse it is for baby, right?
Yep.
Yes. Excellent. Is there anything else that we want to do? So now we have turned her on her left side. We threw the oxygen on her, 10 liters. There's something else we want to do. What else do we want to do?
Notify the provider or
We
the doctor.
definitely want to do that. We definitely need to do that. Yep. But something else we want to do. Yes, Kristen, thank you. Stop the Pitocin. If she has Pitocin running, we want to stop it. Why do we want to stop it?
That drops respiratory rate.
It's not that it's going to affect the respiratory rate. It's that.
Already in distress, so it might cause a further distress of the baby.
Further
and
distress.
There you go.
possibly not make it.
Yes, excellent. Baby's already distressed. Yes, excellent. Good. You guys are doing great. I'm so proud of you. You're doing fantastic. Thank you so much. This is a great discussion we're having today. One more thing we want to do. We're stopping the oxytocin. So we turned mom. We threw the oxygen on her. We stopped the oxytocin if it's running because every pregnant woman that's in labor does not get oxytocin. Okay? Some do, but some don't. So there is one more thing we want to do. Anybody think of what we want to do? We have one more thing we want to do. Well, we're going to have an IV for sure. She has to have IV access. Every woman that goes into labor has IV access. So she's going to have fluids going. She may not have Pitocin going, but she will have fluids. Is there anything we need to do with those fluids?
Them, or give her a bolus of something,
We
possibly.
want to turn them up. Yes. Excellent. Good job, Belinda. Yes, we want to turn the fluids up. Can anyone think why we want to turn them up? Any
We can make
guesses?
things flow more so that we can get more oxygen moving. Things will be flowing more.
That's a good guess, Ron. That is a very good guess. The reason why we want to turn the fluids up is because if we're having an emergent delivery, which is maybe where we're headed, if we can't get baby out quick enough, and we have to end up going for like an emergency C-section, let's say, because sometimes with these late decels, we have to move quick, because these are bad. These are not good. These are the ominous ones, okay, because it's the placenta that is the problem. So anytime the placenta is the problem, what?
What's the determiner as to natural birth or C-section?
Where the baby is at. If baby's head is crowning,
Already
during this
counted.
second stage and the head is ready to come out and that means baby's gonna get delivered, then they'll probably use the kiwi, the suction, vacuum suction, have mom give a really good push and they'll try to get baby out that way. Otherwise, if baby's not even crowning, if baby is nowhere near, I mean, baby's head is engaged, but baby's not crowning, then that means that baby's not ready to deliver yet. So
Okay.
that would be the determiner.
Okay.
Yeah. Does that make sense?
Yep.
Okay. So we want to turn those fluids up because if we do have to do that emergent C-section, we have to do it. We have no choice. This is going to help mom in the long run because we don't want her to have any lowering of her blood pressure because of the medications that we have to give her. So if we give her more fluid, we have more fluid on board, we're essentially giving her a bolus, like Belinda said. That is going to help to prevent that from occurring. Did that make sense?
Yep.
Okay. Great job, guys. You guys did great. All right. This is good. I'm feeling good right now. All right, so now we're going to go into a little more detail on D cells. I threw the case study in before we actually talked about it because I kind of wanted to see where you guys were at, and you guys are right there. You're doing great. Okay, I have an acronym for you because we love acronyms in nursing. So for your D cells, think veal chop. I know it sounds fun. That is the easiest way to remember your D cells. So V for variable. When we are having variable D cells, and they actually look like V's, when you look at them on the monitor strip, they actually do look like V's. When we are having those, that is telling us that there's something with the cord. The cord is being compressed, and someone mentioned cord compression already. Variable is cord compression. So maybe the cord is wrapped around baby's neck. Baby has a nuchal cord, maybe. That's what we call a nuchal cord when the cord is wrapped. Or maybe the cord is between baby's legs, and when the contraction comes, baby squeezes, and that causes compression of the cord. Whatever the case may be, the cord is being compressed in some way. And that is what is contributing to a variable deceleration. Okay? An early deceleration, the E, is the head. Now, with these D cells, we are not concerned about these D cells because we anticipate that they are going to be having some early D cells with head compression. Baby's head's going to get compressed, right, during the labor process. That's unavoidable. And we anticipate that the baby is going to be having some of these early D cells. And they actually will mirror mom's contraction. That's another way that we tell that they're an early, because they do actually mirror mom's contraction when we look at them on the monitor. The A is for acceleration. And it's okay. We don't worry about those either. Baby's heart rate can climb. That's okay. Could be a lot of reasons why baby's heart rate climbs. Could be in response to a medication maybe that mom got or received. It could be any number of things, but we don't worry about those. If baby's heart rate climbs, we don't necessarily worry about those. Those are okay. And then L for late. We just talked about those, right? And the P for utero-placental insufficiency. So the placenta or the uterus are insufficient in some way. Now, there could be lots of reasons for that. Okay, it could be an abruption, as Ron said. The mom's placenta could be abrupting, okay, because of some reason, all right? It could be that mom is post-dates, as in our case study that we just covered, and the placenta is wearing out. It's gone over its time, and now is starting to show signs that it's wearing out, because it's only supposed to last for so long. It could be that we have a rupture of the uterus. Those can contribute to late T cells. Rupture of the uterus is very dangerous. We'll talk about that later because we're going to talk about some of these more dangerous, ominous complications. But that could contribute to a late D cell. Whatever the case may be, it is related to either the uterus or the placenta, and it's bad, and we need to get baby out as soon as possible. We can't wait on those. Once we start having those, we cannot wait on those. We have to get baby out. Because the late D cells occur after the contraction. So that tells us what? If they occur after the contraction.
The baby's stressed, possibly. Still?
Baby is very stressed, but it means that it has nothing to do with the contraction. The rest of our decelerations, they are connected to the contractions in some way. The cord gets compressed because the uterus is contracting. So that's the variable. The head gets compressed because the uterus is contracting. That's the early. The baby's heart rate might accelerate in response to those contractions for some reason, okay? So that, again, is related to the contraction. But the lates have nothing to do with the contractions because they occur after. Does that make sense if I explain it like that?
Yep.
So that's why they are much more ominous. We are very concerned, and we have to act quickly when we start seeing late decels on our monitor. Okay, any questions on the decel? So write this acronym down and take some time to review it. Use it with your studying when you're reviewing before next week's test, because I think it'll be very helpful for you. All right. Any other questions on the decels? Okay. Let's talk about pain management in labor. So this is chapter 13, right? So pain management. There's non-pharmacological, which is more natural, right? The more natural methods, the breathing techniques, effleurage, which is a massage of the abdomen while mom is having a contraction. There is the ball that they can use that mom sits on, and she does her breathing techniques, and she bounces on the ball a little bit while she's having the contractions. Of course, this is all going to occur before we're getting into that transition stage. Once she's in transition, she really should be in the bed, because now we're getting to the finish line. We're rounding third and we're heading for home. So once she gets into transition, she really should be in bed, because we don't really know how long it's going to take her to get from one stage to the second stage, right? To the first, once we get into transition, now we're really going. Everything is happening. Things are really cooking, in other words. Music as a form of distraction, right? Focal point. Find the focal point. Maybe have mom look at something on the wall, or have somebody standing in front of her that she can focus on while she's having the contraction, while she's doing her breathing. This is all a means of distraction for her. So all of these are considered non-pharmacological. They're very natural, right? There's no medications involved. There's hydrotherapy. Now, every labor room at some of the facilities, I know one for certain here in Rockford, have jacuzzi tubs as part of hydrotherapy, so that while mom is going through that labor process, she could get into the jacuzzi tub, and that water, that pulsation of the water, helps to soothe the pain of the contractions that she's feeling. Now, obviously, she's going to have to be careful when she gets in there. She's going to have somebody with her that can observe and be present, right? She's not going to be able to be doing this while she's by herself, because it wouldn't be safe. All right. So non-pharmacological are great techniques that we can teach mom about. Kristen said she loved the jacuzzi tub. It helped a lot. Yeah, I've heard a lot of good things about it. So we want to use a combination of the non-pharmacological with the pharmacological, right? So some pharmacological methods that we can use, things like barbiturates or sedatives, opiates. Now, if you're going to be using those types of medications, especially the sedatives and the barbiturates, those all have to be used at the latent stage, right? The latent phase, early in the labor, because they could cause complications with the actual labor process. So we don't want to be using those as we're getting into that transition phase. We definitely don't want to be using those then. Opiates, we could use as we are approaching the transition phase, but the complication is, yes, Belinda said it, we cannot use them up to 4 hours of delivery because what mom gets, baby gets, okay? And baby could have some respiratory depression after delivery if we have given her opiates, you know, within 4 hours of baby being born. That can cause respiratory depression for the neonate. Okay, so we have to be very careful. We have to be judicious when we are giving these opiates. There's also epidural. I mean, most of you probably that have had labor have had an epidural. I never experienced that, and that just was never offered to me. But a lot of you have had epidurals in the past with your labors. Those of you that have had labor and have had babies, you've had epidurals. So it's very commonly used. Now, it used to be that we wouldn't be able to start those until mom was at least 5 centimeters. But that is no longer the case. They can give it at any stage, at any phase of the labor process that the mom actually wants it, right? Because mom is in the driver's seat here, right? They would optimally like to have her get through the latent phase, and once she's getting into the active phase, then it's appropriate to start that epidural. But we want her to get past that latent phase because we don't want to risk stalling the labor process for any reason, because that only delays things. Okay, so once she's past that latent phase and she's into that active phase, it would be appropriate to start that epidural if as long as everybody's stable and the provider thinks that it's appropriate and everybody's on board with it. Yeah, it would be appropriate to start that. Okay, things like spinal anesthesia, we're not going to be doing that right away. That is a late thing. I mean, that's like right before delivery that we would do that. We are not going to be doing that early on in the labor process. We're not going to be giving those types of meds. Epidural, yes, but not spinal anesthesia. If they've had spinal anesthesia, a lot of times, depending on the type of medication that they are using, those medicines can stay in the mom's system for up to 24 hours. So a lot of times they're going to be restricting her activity, may even be putting her on complete bed rest for that up to that 24 hours until that anesthesia has worked its way out of her system, because that's how long some of those medications can stay once they're put in. Okay, so we do have to be aware of that. There's also general anesthesia. Now, obviously, this is not something that we're going to give just to, you know, if mom tells you, I'd like to be knocked out for the delivery. First of all, I'd be very concerned about that. I don't know why she would want to be knocked out, but that's not something that we're going to do. Okay, she's not going to get knocked out just because she wants to be knocked out. Okay, they use general anesthesia extremely judiciously. There has to be a precipitating cause for them to put the mom under general anesthesia. That's like for an emergency C-section. They're going to knock her out because they don't have time to mess with epidurals and spinal anesthesia and all of those things, because all of those things take time to take effect. We don't have time for that. So in an emergent situation, they're going to knock mom out and they're going to use general anesthesia. But again, remember what I said. What did I say about medications?
What's in the mom goes to the baby.
Excellent, Ron. Thank you. What mom gets, baby gets. So if mom has had general anesthesia, so has baby. Okay? So we do need to be aware of that. Remember that third stage where we are monitoring baby, because now baby's here, so we're monitoring baby and we're monitoring mom. So if mom has had general anesthesia, then we need to be alert to the fact that baby might be a little depressed when they come out. They might be very sleepy, groggy, maybe not breathing very actively, right? So we do need to be aware of that. Baby might need a little bit more help after delivery if mom has had general anesthesia. Does that make sense for everybody?
Yeah, when you said the spinal anesthesia, when do they typically do that? You said closer to
Before delivery. Before delivery.
right before.
Yes.
Right, that's what I thought. Okay.
Mm-hmm. Yep. Yep. Exactly. Now there's blocks that they can do, and that is also going to be done before delivery. So something like what they call a pudendal block. So there's the pudendal nerve that comes down into mom's vagina. So they can inject, that's an injection, like it's almost like a local anesthetic, if you want to think of it as a local. So they will inject their medications into that nerve to numb that spot. So basically mom's peri area is going to be all numb. Now, some circumstances that they would need to do that if they need to perform an episiotomy. Tell me what an episiotomy is. Does anybody know what that is?
Surgical cutting.
Of?
The vagina.
Perineum to
Yeah,
prevent
vagina to the
filth or
anus.
clean.
Yes, not fun. Not fun.
Tear.
Let's just say not fun. It's an actual incision that is made between the vagina and the rectum to make that canal, make that opening wider to prevent any lacerations or tears. Okay? Because if they have a really large baby, her pelvis is really small, or her opening is really small, hasn't really stretched very much, then she may experience some tearing when baby comes out. So episiotomies are a pretty common procedure that is done, and a lot of times they will use something like a pudendal block if they're going to do that type of procedure, because they want that area to be numb when they're cutting. Okay?
Or if the baby's breech and they have to reposition.
They could, yes.
Yeah.
Now, in that case, what could we do to reposition baby?
Well, we're going to do that before.
Change her
Right there.
position.
But is that going to reposition baby?
You put your hands on her belly and you try to maneuver him.
Right. And what do we call those maneuvers?
Oh,
At the tip of my tongue.
yeah, me too. Phone a friend. Phone a friend.
The Leopold maneuver.
Leopold's. Yes, thank you, Renee. Yes. Leopold's maneuvers. But what's the caveat to that? When we're talking about repositioning baby, who is going to do those Leopold's maneuvers?
Nurse.
No.
No?
Not to reposition baby.
Oh, not the
Yes, the provider. The provider will do those maneuvers. If we're talking repositioning of baby, the provider has to do them because they're much more aggressive, and it is painful. It is very, very painful for the doctor to do those to try to get baby to turn. And baby doesn't always turn. Sometimes they'll maneuver and then baby just flips right back where they were. So sometimes it takes a while of doing
You
those
were braced,
maneuvers.
weren't you? So she fucked it up.
So sometimes it takes a lot of those maneuvers by the provider to get the baby to turn. And the baby doesn't always turn. Sometimes the baby goes right back where they were. And after, you can't spend a whole lot of time doing that, especially when we're rounding third and heading for home, because, things are going to happen relatively quickly. So, we don't want to be spending a whole lot of time. The second stage of labor, the pushing stage, can take up to 2 hours. That seems like a lot of time, but when you're trying to mess around with moving baby around, that's not a whole lot of time. So we don't necessarily want to be doing that. So I was involved with a delivery of twins, and mom wanted the babies to be born vaginally if at all possible. So the first twin was born vaginally, but we had them in the OR because the second baby, the B baby, was transverse. What do I mean by transverse?
Laying across.
Yeah, like perpendicular.
They're sideways. Think of it as being sideways. Yes. So the shoulder basically would be coming first because of the way the baby's laying. So the B baby was transverse. A baby came out, beautiful, no problem. So here's the doctor trying to turn the B baby, turn, because mom really wanted the babies to be born vaginally if at all possible. She was terrified of having a C-section, and she really wanted them to be born vaginally. It didn't seem like it, it felt like a long time to me, sitting there waiting right? Because I'm waiting for that baby to come out because I'm the one that's going to be taking care of that baby when it comes out. And I'm waiting and waiting, and it seemed like it took a really long time. In actuality, it didn't, but it was unsuccessful to say the least. So mom did end up having to have a C-section for baby B. So sometimes those maneuvers are not always successful. Sometimes they are, but sometimes they aren't. Okay, good. Excellent. You guys ready for our next case study? Because here it comes.
Yeah.
Here we go. All right. We have a 23-year-old prima gravida. Tell me what prima gravida means.
First
Pregnancy.
First pregnancy. All right. So her health and pregnancy history are unremarkable. She's had adequate prenatal care throughout the pregnancy. Is that good? Please tell me yes.
Yeah.
So far, so good, right? Health
Better
and
than
pregnancy, unremarkable. She's had good prenatal care. She has a birth plan, and part of her birth plan is to not receive pain medication during her labor. She wants a natural childbirth, and she wants her mom to be present at the delivery. Okay? Does that all sound good so far?
Yeah.
No problems yet. So we perform the Leopold's maneuvers because we want to know where baby's at. So the fetus is a longitudinal lie. So what do I mean by longitudinal lie?
upside down. Going like it's vertical.
Right. It's longitudinal, meaning up and down. That's all that means. Zero station. What do I mean by station? Zero station. Anybody know what I mean by the station?
The head hasn't descended at all yet.
Not necessarily. You're on the right track.
Is it how far dilated?
Nope. It doesn't have anything to do with the cervix. It's only about the baby.
Something like it's equal with the pelvis. It's in right position, right in the center. Not up,
Yeah.
it's not down.
Yes. So the mom's pelvis is, if you see the picture on page 421 of your textbook, it has it numbered. You can see the baby's head coming down into the pelvis, and then you see a bunch of hash marks with numbers. So that is the station. And it's all in relation to the ischial spines of the mom's pelvis, those little protrusions that come out at the pelvic inlet. So that is zero station. That means that the presenting part, and that doesn't necessarily mean the head, it just means that the presenting part is at the level of the ischial spines. Once the baby gets to zero station, they are now what we call engaged. It's engaged in the mom's pelvis once the baby gets to zero station. And we have a cephalic presentation. So what do I mean by cephalic presentation?
Head first.
Yes. Is that what we want?
Yes.
Absolutely. That is exactly what we want. So baby is in a longitudinal lie, meaning up and down. Zero station, meaning that the presenting part is engaged. And they are a cephalic presentation, meaning that what is presenting?
Head's down.
Head. Yes. So far so good, right? We're on the right track.
Everything's perfect.
Everything's looking good. An amniotomy has been performed by the provider to augment the labor. This is a prima gravida, so it takes a long time for the labor. But she doesn't want to have medication, right? I don't want any pain medication. So, in order to try to avoid using medications to augment labor, we're going to do an amniotomy. What do I mean by amniotomy? Does anybody know what I mean by that?
Is that the breaking of the water?
Yes, excellent. Artificial rupture of the membranes. Once we do that, that sends the mom's body a signal, hey, we got to start labor. The membranes are ruptured. We got to get this process going. Baby's ready to come out. All right, excellent. Very good. So now we have done, the provider did that because the provider does that. We don't do that. Provider does that. So now we've been called into the room because our patient is saying that she feels something between her legs. We gotta do a little investigation. Now our fetal monitor is showing variable D cells during contraction. What do I mean by variable D cells? What did we say?
The sharp V's. The
Yeah,
monitor.
but what is the cause? Cord. Yes, Kate. Thank you. Cord. All right, so what potential complication is occurring? Not exactly, Jen. It is related to the cord, but it's not a nuchal cord. It's something else.
You
Compression.
may have presented.
Prolapse of the umbilical cord.
Prolapse is what I was looking for.
Congratulations. Yes, cord prolapse. A lot of times we have a cord prolapse when we have the rupture of the membranes. If you think of it as that old saying where we throw the baby out with the bathwater,
Right.
the cord comes out with the rushing of the water.
Yep.
Okay. All right. Excellent. So now what's our role and responsibility? This is our patient. We pull the covers back and we can see the cord. This is not good. What do?
We
Hold the
just
cord
lift it
up.
Oh, no.
No?
No, I thought
Nope. We don't want to hold the cord.
the pressure off.
We do want to get the pressure off. You're right, Natasha. You're on the right track. Does anybody want to help? We don't want to actually touch the cord.
You push into the
Oh, wrap it.
presenting
Do we
part.
wrap it in
Is
the
saline.
saline, like a saline soaked like towel or something?
Well, let's talk about priority. Okay.
Sterile glove.
Sterile glove. We got to put a sterile glove on because this is all sterile, right? We want to keep it sterile. We don't want to risk potentially infecting mom in any way. So we're going to put a sterile glove on. What else are we going to do?
Push on the presenting part
Yes. And why are we going to do that?
to relieve pressure from the cord.
Yes, that is how we relieve pressure on the cord, by lifting up on the presenting part. We put that sterile glove on. We take 2 fingers and we are lifting up on the presenting part. But we do not want to touch the cord. So why do we not want to touch the cord? Because it would make sense, right? We want to lift up on that cord, right? That would be your first thought, wouldn't it? But why don't we want to touch the cord?
Put off the oxygen to the babe.
It could contribute to it, but there's something very specific that could happen if we were to touch that cord. It has to do with that tactile stimulation. Anybody have any ideas? Anybody want to guess? Vasoconstriction.
Vasoconstriction.
It causes a clamping down of the cord. And what happens if it clamps down?
Baby's gonna not get oxygen.
There you go. So we have that clamping down of the cord. That's going to cut off the oxygen supply. That's going to cut off the perfusion to the baby. Excellent. Does that make sense, guys? When you think of it that way, why we don't want to touch the cord. Now, someone mentioned about this sterile drape. If we have time for that, once the cord comes out, baby has to come out. We can't push the cord back in because we can't touch the cord. So once the cord is out, baby has to be born. We have to get this process precipitated very quickly. We don't have time. Okay. So if we have time where they're just getting things set up, then we would take a sterile drape that is moistened with sterile saline, and we would place that over the cord. But that's only if we have time for that. Okay. Our priority is to relieve the pressure on the cord, right? And to make sure that we're getting things rolling. Now, if you come in that room and you pull that cover back and you see that the cord is out, what do you want to do? I mean, besides, we went through our steps, but is there something that you want to do very quickly before you start doing your steps?
Maybe notify the physician.
How about your coworkers? Get help in there.
Anyone?
Anytime you guys are involved in an emergency situation, don't do it alone. Get help. You know, pull the cord out of the wall so that the emergency starts flashing so that people know there's a problem. put the call light on, pick up the phone, whatever the case may be. Nowadays nurses have cell phones that they use for work, right? So you get your cell phone out, or you use your Sarah, or whatever the case may be. You need to get help in there. You do not want to be in this situation by yourself. When the help comes in, because in labor, everybody responds to an emergency, not just one nurse, all of them that are available are going to respond to that emergency, because we all know that things have to happen fast when we have an emergency. So then you can have somebody get a hold of your provider. You let them know who it is, say, get a hold of them right away. We need this going. Let them know what's happening and tell them they need to get here right away.
Because they have to go to C-section, right?
They may have to. It depends on, again, where is baby at? Is baby ready to deliver? If baby's ready to deliver, then they could go ahead and let baby deliver vaginally. If baby's not ready to deliver, then we have to do a C-section, because once that cord is out, baby has to be born. It has to happen
Like within
quickly.
5 minutes or what? Like within 10 minutes?
Within let's say 30 minutes.
Okay.
Yeah. 5 minutes, you're not going to have enough time to get mom to the OR in 5 minutes. But 30 minutes, yeah. Yeah. That's about how long it would take to get everybody there, get the anesthesiologist there, get the doctor, the provider there, get everybody there. Does that make sense?
Someone is potentially just pressing on the presenting part.
It would be the primary nurse.
The primary nurse would be
you're
the whole time.
The whole time you have your hands between mom's legs and you're lifting up on that presenting part. Now you can turn her on her left side. Okay, again, because we want to increase that oxygenation. So you could put her into like a modified Sims position, and where she's not on her abdomen, but she's off of her back. She's laying on the side, but you still have to have your fingers in there lifting up on that presenting part. Because every time mom were to have a contraction, and now we're in transition, so, contractions are coming quicker, it's going to cause a potential clamping of that cord.
Right.
Okay. If you have enough time, let's say you have 30 minutes before you're going to be able to get into the OR, and you're there and you're lifting up on stuff, then that's where you're going to take that sterile drape and you're going to put that sterile drape down. But in order of priority, you got to get your fingers in there and you got to lift up on that presenting part. That's your priority.
Do like nurses relieve each other with this? Like it's kind of like CPR, or is you can just sit there? For 30
no,
minutes?
you are it.
That
Yep,
you are it.
You're
Okay.
you're it. Yeah, it's the primary nurse that's going to be responsible for that. All right, good job, guys. All right, so very quickly before we end for today, I'll just talk about some of these complications that you guys are learning about. All right, so we talked about cord prolapse. Abruption, we've talked about abruption. That's where the placenta is actually detaching from the uterine wall. That's bad news, right? That's not good. Fetal malpresentation. So if baby were in a transverse lie or in a breech presentation, that could be considered a complication because baby's not going to be able to be born vaginally. I mean, they do deliver babies breech vaginally, but very, very rarely. There are a lot of complications that could happen to baby if they were to let that type of presentation deliver vaginally. So it's very high risk, and the majority of providers are not going to do that. If they can't turn baby, then they're going to be delivered by C-section if they're a breech presentation. Transverse lie cannot be born vaginally. I mean, baby's not going to fit. Okay, so that is not going to be conducive with a vaginal delivery. Non-reassuring fetal heart rate patterns, if the baby's having those D cells. Now, we expect there to be some variable D cells in there. We do expect that. We actually need that because we want to know that baby's neurologic status is intact and that baby responds to those contractions by changes in their heart rate. So that tells us that the baby's neurologic status is intact. We don't want a lot of them, though. We don't want them to be clustered together and having many, 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 many of them. Okay, we don't want that. Uterine rupture, I mentioned that very briefly earlier. That is where there's actually a hole that, a tearing of the uterine itself, the uterus itself. In this case, this could mean death to mom and baby. This is a serious emergency. They got to get baby out, and it has to happen fast, because baby could actually go through that tearing into the mom's abdominal cavity. So this is not good. A uterine rupture is bad, bad, bad.
I have kind of a story to share, if you don't mind.
Oh, sure, go ahead.
So, my last two kids are only 10 months apart. Yeah, that was a oops. Anyway, they didn't diagnose me with preeclampsia with the last one, but they didn't rule it out either. I was like right on the borderline.
Okay.
So they induced me at 37 weeks with her. And apparently they didn't read all the charts and everything, because they had started Pitocin and everything. And the doctor came in and he realized that my last one was only 10 months ago. And he told me that they needed to stop. And then we were going to go for a C-section again. And so I asked why, whatever. And he described the uterine rupture. And I was like, well, can't we just try? And he's like, look, this is what happens with a uterine rupture. He goes, ultimately, baby is going to be in your guts. You both could die. Is this what you want to risk? And I was like, yeah, no, never mind.
He was a little forceful there, but
yeah,
the risk is there. But as far as letting a woman deliver vaginally after having a C-section, that is totally provider driven, really, because the provider has to accept that responsibility that he is allowing you to have what they call a trial of labor. Not all providers are willing to do that. Remember I said a while back that this is the highest litigated area? There's reasons for that. Now, they've done exhaustive research, very, very extensive research. A lot of the OBs and the gynaes have done a lot of research into what we call VBAC, vaginal delivery after section. So they've done a lot of research, and they're finding that the risk of uterine rupture is not as high as they once thought it was. But again, it's provider driven. Your provider has to be willing to accept that responsibility to allow you to have a trial of labor. And it used to be that the providers, like your provider, are very adamant, no, not doing it. This is why. That culture has been changing slowly, but it's a slow change. There's still a lot of providers out there who are not willing to risk. So
is that just because there was a complication before, so we're just like we're minimizing the risk?
There is a risk. I mean, once that muscle has been opened, you've had a section now, you've surgically opened that muscle tissue. Once it's not going to have its same tensile strength anymore.
Oh, okay, that makes sense.
Does that make sense if I explain it like that? Yeah. So then when she's having those contractions, the pressure that's being applied to that muscle could potentially cause that rupture. Does that make sense if I explain it like that?
Yeah, it does.
Yeah, that was his main worry, because I had only had the 10 months to heal, and he's like, oh my God.
Yes, you hadn't had enough time for healing, yes. So I can understand his thought process. I really can. I don't think he was trying to be a jerk about it. I think he was just really concerned. I don't think he wanted to risk it, and I could see his thought process with that.
I didn't take it like he was being a jerk. I was like, oh, I think that's just what I needed to hear to understand the seriousness of it. And I was like, okay, never mind.
Well, sometimes, I think we try to explain things a little more delicately, but I think he was like, oh no. It's only been X amount of months since you had the last baby and you had a section with that baby. And, I think maybe he was just like, I really just have to give it to you straight out. And I think that was the whole thing. So, because we do try to be a little more delicate so that we don't scare the client, because we don't want to scare you, We don't want to scare you into doing what we want. or what we think is right. At least the majority of us don't. There are those out there who use scare tactics. They do. I don't agree with it, but there are those that will. I'm not one of them. And then our last complication, the anaphylactoid syndrome. This is kind of, if you think about a pulmonary embolism, this is an actual embolism that occurs inside the amniotic fluid. So this could potentially go to mom's lungs or go to her heart. So this would be a very high risk, potential mortality type of situation. High mortality for mom and for baby. So this is a serious thing that you want to avoid at all costs. You want to be on high alert.
What causes that?
Sometimes it can be caused if mom had an amniocentesis procedure done and there was an actual puncture to the amniotic sac. That can sometimes contribute to an anaphylactoid embolism.
Wow.
It's not that it's real common, it's just something for us as the caregivers and care providers to be aware of. It's actually a very rare thing. It doesn't really happen all that often. But again, it is something to be aware of because there is a high mortality that could occur. Yep. Sometimes if you have a transfer, there's that chance that a little bit of mom's blood and a little bit of baby's blood are going to mix. And sometimes if that occurs, an anaphylactoid syndrome can happen to mom if that were to occur because her body would attack. Right? If the RH factors are different between mom and baby, mom's body may attack that little bit of stuff that gets mixed in the fluid, and that can also contribute. All right. You guys did great today. I'm very impressed. All right. Any questions over anything we covered today, guys, before we end for today? I'm going to go ahead and stop sharing my stuff over here. Okay. Well, thank you guys so much for coming. This was a fantastic discussion. I really appreciate you guys taking time to come to class. Thank you so much. I hope you found it valuable. If you do have any questions for me, please reach out. Feel free to reach out to me. Those of you that have clinical today, I'll see you at 12 o'clock.
So we have
Have
an
a great-
exam next week?
You do, next Monday.
Okay.
Yep.
9 to 11, correct?
The link is available starting at 9 a.m. until 11 a.m. You have, it's 50 questions and you will have 60 minutes once you start.
Thank you so much.
You are welcome. Thank you guys for coming. I will be posting that concept review by the end of today for next week's exam that you guys can use to create your own study guide. I'll be posting that by the end of today, so be looking for that. I'll put it under Module 4.
Under 4, got it. Thank
Yep.
you.
You're welcome. All right, guys, have a great rest of your day. Those of you that have clinical, I'll see you at noon.
Laura, I missed the first few minutes of lecture today. Did we go over assignments at all for the week?
No, I did post an announcement, though.
Okay, I'll go and look at that before I ask any
Yeah, and
questions.
if you have any questions, let me know. Just reach out. Let me know.
Okay, thank you.
You're welcome.